Hi, welcome everyone. My name is Laurie Longest. I am a physical therapist by trade. I am an MNRI core specialist and an instructor, and I have the honor of organizing our intensive therapy conferences for clients with a diagnosis of HIE, which stands for hypoxic ischemic encephalopathy, and NFD, which is non-fatal drowning. I wanted to welcome you to today's presentation, MNRI, a spark of hope for hypoxic brain injuries. And the slide picture that you are looking at here was taken just today, which was the last day of our most recent conference. And you can see a grouping of very happy families, happy children, and happy MNRI core specialists. So welcome to today's presentation. So this is the abstract for today's presentation. And MNRI has been referred to as what's called the missing link for neurologically based challenges by addressing brainstem skills instead of using what is considered a traditional cortical approach, with the end goal being integration of primary reflex patterns. MNRI also addresses regulation of the sensory system, muscle tone, the auditory, visual, vestibular systems, oral motor coordination, and trauma recovery as parallel challenges. This presentation will introduce you to the amazing tasks of primary reflexes as a basis for protection and survival, neuroplasticity, and neurodevelopment. The bulk of today's lecture will then continue with an explanation of how MNRI can facilitate development, or in cases of post-birth accidents, redevelopment of motor skills, feeding, language, cognition, and social skills following a debilitating hypoxic brain injury. So today you are here to find out how MNRI is a spark of hope following these tragedies. Welcome. I would like to start today's lecture with explaining to you exactly what is a hypoxic brain injury. So today we will start with the respiratory system and just learn a little bit about how oxygen gets to all of the tissues in our body. The purpose of the respiratory system is to perform gas exchange between oxygen and carbon dioxide. And this gas exchange takes place at two locations in the body. First, in the lungs, in the lower lobes of the lungs, oxygen is picked up by the red blood cells, and carbon dioxide is released from the red blood cells. This is known as external respiration. Then the red blood cells travel throughout the body to the different tissues, and once they get to the tissue, oxygen is released into the tissues, and carbon dioxide, which is the waste product, is picked up to be taken back to the lungs. This is known as internal respiration. So it's through these gas exchanges that blood and tissue is both oxygenated and the waste from the tissue is removed from the body. So how does this gas exchange take place? Because the red blood cell does not just give all of its oxygen molecules away and pick up all of the carbon dioxide from the tissues. Gas tends to move from an area where the pressure is higher to an area where the pressure is lower. So that means as the red blood cell comes up to the tissue, it will find that the tissue is mostly full of carbon dioxide, where the red blood cell is mostly full of oxygen. So they will exchange just enough gas between the two of them that the levels of oxygen and carbon dioxide will be equal. One red blood cell can travel the circulatory system in 1 minute. All right, so these are important things to think about because we're going to be thinking about what happens when we're no longer breathing and getting oxygen into the body. So it's important to understand how much oxygen is left in those red blood cells and how quickly those red blood cells can get to all the tissues in the body. Hypoxemia means that there is less oxygen in the red blood cells than what would be considered normal. Now, how could hypoxemia become an issue? How would one get hypoxemia? So there has to be, first of all, enough oxygen in the air that you're breathing. And oxygen in the air is approximately 21% of the air that you breathe. We also have nitrogen and some other gases in the air, but a majority of the air is nitrogen, but oxygen only accounts for 21%. So if you are in a higher altitude up in the mountains, or say you were choking on a piece of food, or you have a collapsed airway, so you're only getting a little bit of air in, or perhaps you were in an enclosed space, such as a mining accident, when you're stuck in a cave, and you are breathing in the oxygen, but exhaling the carbon dioxide. Eventually, the cave is going to fill with more and more carbon dioxide and less oxygen. So these are just a few cases where you could have a case of hypoxemia because there is not enough oxygen in the air that you're breathing. Another cause of hypoxemia is that the lungs need to be able to function properly for that gas exchange to take place. So if you have fluid in your lungs, or if you have lung cancer, if you have damage to your lungs, if you were a firefighter and you've had years of smoke inhalation and there's damage to the lungs, then the gas exchange, the initial gas exchange that takes place in the lungs may not be ideal. And then another cause could be that perhaps you don't have enough red blood cells in your body. Or maybe you do have the red blood cells, but you don't have the hemoglobin that's inside the red blood cells, which is what the oxygen is going to attach to. So when you have a case of hypoxemia and the oxygen in your blood cells is minimal, then once you get to the tissue level, remember that gas exchange wants to equal out, right? So we're not giving as much oxygen to the tissues either. We're only giving, what the red blood cell can offer to make those, the red blood cells and the tissue equalize. And then without oxygen to the tissues, now we're going to have organ dysfunction or even organ death. So remember that carbon dioxide and oxygen gases in the red blood cells and tissues want to equalize. So that means even less oxygen will be exchanged. The red blood cell does not just give up all the oxygen it has when it gets to the tissues. A second cause of hypoxia, so the first was hypoxemia, right? That there's not enough oxygen in the blood cells. So another cause of hypoxia, or low oxygen, is poor circulation. And again, those red blood cells cannot get to the tissues to provide them with the oxygen that's needed. And this could be due to a medical condition such as diabetes, PAD, clots, obesity, or even heart failure, or it could even be some kind of an outside restriction that you see in the picture below where the wedding ring is cutting off the circulation in the finger. All right, so we have lack of oxygen in the red blood cells, or enough oxygen in the red blood cells, but they're not circulating through the body. Okay, so I wanted to show you this picture today because the brain does some pretty amazing things, and the body does try to protect you when something arises where you are getting less oxygen than you should be. And so this is the arterial system that goes with the brain, and you have, some huge arteries that come up from all over the body. But as you can see, you start with the larger arteries, your carotids that you can see in this picture. And as it gets up into the brain, the arteries get smaller and smaller. So you do have three main arteries that go to the brain: the anterior cerebral, the middle cerebral, and the posterior cerebral arteries. But what happens is that when we go into hypoxia and we don't have enough oxygen, then the ends of the arterial circulation there, all the tiny little end pieces, they are that's where you're going to suffer from not getting the blood. Kind of like your air conditioning unit, right? In the room that's like at the end of all the ductwork and everything, that's the one that doesn't get all, as good of air conditioning as the other parts of the house. So where the X's are, these are called the watershed areas. And what watershed means is that they're not really oxygenated by any one artery. They're oxygenated by several arteries, but it's the very tips of those arteries that are giving the circulation. So that's the area that is really affected the most when we have loss of oxygen to the brain. So if low blood flow to these watershed areas lasts for longer than just a few minutes, then the tissue in that watershed area will begin to die within just a few minutes. So remember, I said that the brain is pretty amazing and it tries to prevent all of this damage. In the beginning, there is preferential shunting to vital brain structures, meaning that areas that are not as much of a priority are not going to get all of the red blood cells. They're going to send those red blood cells to the most prioritized areas, and that's the brainstem, the cerebellum, the thalami, the basal ganglia, and the hippocampi. Of course, that is done at the expense of the cerebral cortex and the white matter of the watershed regions. Watershed injuries in general are usually symmetrical. They're bilateral, so the injury occurs in the same areas on both sides of the brain. And some of the symptoms that you would see, especially in the beginning when it's, you're very first going into that hypoxia state, is weakness or paralysis, usually the legs more so than the arms, again, because the brain is shunting those areas and trying to get more and more oxygen, especially to the heart, right? You will have higher risk for seizures and some vision loss. This is just very, very low, mild hypoxia cases. So you can have pure hypoxic arrest. So that means we've lost breathing, but you still have a heartbeat. And so as long as you still have that heartbeat, you are going to have continued delivery of oxygen from the red blood cells that still have oxygen in them that are circulating throughout the system. And you will still have continued removal of the toxins of that carbon dioxide, because again, you're still circulating around the body. But as that CO2 increases, the vascular system will automatically dilate in order to increase the flow, the circulatory flow, and again, get oxygen to the tissues. And so what usually happens when you only have the respiratory, the loss of oxygen, and you have not yet affected the heart, is the damage there is going to affect the neuronal synapses. You don't really have cell death, but the connection of one neuron to the next neuron in order to create a circuit or a pathway, that's where the damage is going to take place. So the neurons are all there, they've just lost connection with each other. And this type of hypoxic injury does have a better chance for survival and neurological recovery than those who actually end up with an HIE diagnosis where the damage is greater. So let's talk about what happens, to where we have complete shutdown. So here we are trying to get oxygen to all the important tissues in the body, but if the hypoxic event continues, now we're going to have less and less oxygen going to the heart. The heart is a muscle, and then the heart will stop, and then you go into full cardiac arrest. So now there's no circulation, even if there is a little bit of oxygen left in those red blood cells, circulation has completely shut down. So what is HIE? Hypoxic ischemic encephalopathy. This is brain injury that's caused by severe brain deprivation, oxygen deprivation. The hypoxic, I've just broken down the word here, HIE. H stands for hypoxic, which means lower than normal oxygen level in the arterial blood. Ischemic stands for an inadequate blood supply to an organ or a part of the body. And encephalopathy means disease or damage to the brain. HIE can occur prenatally in utero when you have inadequate perfusion from the placenta, such as a prolapsed cord or a placental abruption. But it can also come from other matters, such as acute maternal hypotension. So when mom's blood pressure drops, baby's no longer getting as much blood either, and therefore not as much oxygen. It can occur intrapartum, which is during the labor and delivery process itself. That can be from meconium aspiration or from hemorrhaging. And then it can also occur postnatally, and this can be for so many different reasons. And I just put a few of them here: pneumonia, congenital heart disease, illness, any kind of injury, including our non-fatal drowning injuries, or any other reasons that we mentioned earlier in the slides where I talked about just generalized hypoxia with like the wedding ring and the diabetes and all of that. HIE due to fetal or neonatal asphyxia is a leading cause of death or severe impairments among infants. And these are some of the symptoms that you will see in the very beginning. Slower heart rate, the skin could turn pale or blue, you will lose muscle tone, there will be very weak breathing or no breathing whatsoever a little bit later. And then the APGAR scores, which is a scoring system to see how healthy a newborn baby is. They look at 1 minute after birth and 5 minutes and 10 minutes after birth. the APGAR scores will be very low. So remember, when you just had loss of the respiratory system, but the circulatory system was still working, all we had was the loss of the connections of the neurons. Now we are going to have damage to the neurons itself. Loss of blood flow to the brain more than 3 or 4 minutes will lead to brain tissue damage. And even if you can reestablish the circulatory system, and even if you're doing, CPR and you have circulatory system going, plus you're adding more oxygen, even by reestablishing that, it is not going to stop the cell damage. Once the cell damage begins, you cannot stop the sequence, the chain of events. So let's talk just a little bit about that chain of events. There are 2 phases, the primary phase and a secondary phase. So in the primary phase, you have that hypoxemia and diminished oxygen getting to the tissues. And then on a cellular level, your sodium and your potassium pump is going to fail. And this is an exchange that takes place between the membranes of the cell. And when that pump fails, now the entire cell membrane is going to depolarize, which is going to change it chemically. And now there's no barrier, and everything and anything can come and go in and out of that cell. And here is where you're going to get the damage. There are 2 different types of damage you can get to the neurons. You can get apoptosis, where the neuron is going to shrink in size, but that membrane still remains intact. And then you have necrosis, where the membrane itself ruptures, and that's going to not just cause scar tissue, but it's going to, now you've put toxic waste all out to the surrounding area. So you're looking at damage to everything that has touched. So after this primary phase, you do have this a little bit of a latency period that can be, anywhere up to 6 to 48 hours long, the latency period. And during this latency period, blood flow is restored, and there is a brief recovery of the metabolism that's going on in the brain, getting nutrition and taking away waste. And but the more severe the insult, the shorter this latency period will be. And this latency period is the best time to jump in with therapeutic intervention. And the intervention is not so much to try to correct the damage that's already occurred. It's to try to prevent further injury that's going to occur during the secondary phase. Because now that we have damage, initial damage in the brain, our body is going to send all kinds of help to the brain to try to clear out the toxic waste, and there's going to be inflammation going on, and all of the things that take place in order to fix the damage that's there. And unfortunately, that causes even more damage. So the goal of this during this latency period is to prevent further injury that's caused by the ischemia, the edema, the hypoxemia, the pressure. Just think about, you get all this inflammation in the brain, and now there's no room for inflammation. We have a tiny bit of a buffer in the brain before you get to the skull. And if the brain is swelling, there's nowhere for it to go. So it's pushing against the skull bones and against, all the pieces and parts in the brain, and can be damaging other areas. The electrolyte imbalance, so nutrition, acidosis, and also prevention of seizures. And as I said, that secondary phase starts anywhere from 6 to 48 hours later. And now you're going to have inflammation and toxins from that primary phase that's going to cause even more damage. So that's why I said that once the chain of events has started, right, it's just going to continue. You've already, knocked over that first domino, and your entire row of dominoes is going to fall. So what are some of, and these are medical strategies, because at this point you're in the hospital, in the emergency room. And so these are your short-term acute care strategies. Each case of HIV is unique, so there really isn't a specific protocol that takes place. Treatment is individualized and based on the type of damage that was done to the brain. The length of time without oxygen is mostly what determines how severe this condition will be. So what are we looking for in the hospital? Just restoring the breathing and circulation, trying to keep that inflammation down, possibly by elevating the head of the bed, using diuretics to try to get rid of some of that inflammation so that there's not so much pressure, to decrease the volume of fluid that's in the brain, controlling seizures and balancing the sugar levels. And then some other controversial things that they are doing is inducing mild hypothermia. And by just chilling the brain just a tiny bit, 6 degrees, or 6% for every 1 degree, is what you can save with the metabolic demands of the brain. So just by cooling the brain a tiny bit, you can save it, because it's not going to need as much oxygen and as many nutrients as it would need at a normal temperature. Now, the trick there is it must be a very mild hypothermic state, because once you start going a little deeper into hypothermia, then there can be some side effects with the heart and some other parts of the body. But hypothermia has been used successfully since the 1950s to protect the brain against ischemia during open heart surgeries. Other benefits include that of the hypothermia is that it constricts the blood vessels just a little bit, which helps again to decrease the volume of the blood, which is another way of trying to limit the pressure that's going on inside the skull. It will help decrease toxins and the inflammatory cytokines and help prevent that apoptosis. And then the long-term medical strategies are just to support, to address continued complications, which could be myoclonus, epilepsy, nutritional concerns, muscle tone regulation, cardiac damage, and lung damage, and of course, a multitude of other issues as well. The other long-term strategy, once you are medically stable and ready to be discharged from the hospital, is therapy. And they will send you to therapy to help you recover all of the developmental skills that you have possibly lost, to help re-regulate or regulate that muscle tone, to address cognitive impairments, behavioral dysregulation, feeding and motor impairments, all skills that you, if the injury occurred after birth, perhaps you had and you lost, or if it occurred during the birthing process or prior, perhaps you never had to begin with. So all of the different therapies to address those needs. So it's about recovery here. So this is where MNRI comes in. So let me introduce you to MNRI. A child's development from 0 to 10 years old is based on the extrapyramidal nerve net system. This is the part of the brain that sits below the cortex, subcortical and brainstem level. So what you can see here in these pictures is on the top row of pictures here, the subcortical oriented teaching and learning. I have circled the more brainstem of the brain there. You can see a little bit of the cerebellum and a few other pieces. But by addressing the brainstem level, you are building a nice, sturdy foundation for the house that you can see that's next to it. Cortical-oriented teaching and learning, where you're addressing the cortex, the top part of the brain, that is giving you, that's like starting from the top down instead of from the bottom up. So that's why this house is upside down here. So we're trying to put the roof on the house before we built a foundation for this house. And you can imagine how unsteady that house is being in that position, that we haven't laid down our solid foundation yet. So MNRI stands for Masgutova Neurosensory Motor Reflex Integration. And this is a picture of Dr. Masgutova, who is our founder. And she has a history as being a developmental psychologist. And these are honestly just a few of her hundreds of accolades here. She's an associate professor. She is Russian. She's an associate professor in Russia, researcher for the Russian Educational Academy. She spent a few years in medical studies and massage school so that she could learn more about how the body works. She has a postgraduate degree in clinical neurospeech development. She lectures for early intervention. She's a director of our institute in Poland and our institute in the United States. She's authored over 200 publications, and this is just honestly a blink of an eye about this incredible person. Beside her in this picture here is Pamela Curley, another very incredible person, and she is the co-founder and brought MNRI here to the United States and is best friends with Dr. Masgutova, and encouraged her to write the book that you can see on the screen here called Trauma Recovery, You Are a Winner. This book is available to download for free on the Masgutova website that you can see at the bottom of the screen, masgutovamethod.com. And it's the story of how Dr. Masgutova started her journey into creating MNRI. It's a wonderful story. So I'm not going to tell you the whole story here, but there was a pretty horrific train accident in Russia, and there were quite a few injuries. Many of them were children, and Dr. Masgutova took a sabbatical from the university so she could go to the hospital and help. So she was planning to be gone just a few weeks and ended up staying for 6 months. And she was trying all types of, she first started with just traditional psychology type techniques, talk therapy and art therapy, to help the victims, but she found that it wasn't really working. So then she started doing some hands-on therapy, and this is where she saw progress. So she made amazing, amazing progress and taught many others in the hospital techniques to do with other patients that were there. And then she came back to the university and she said, okay, I need to figure out what I did. Why did this work? So she really started investigating here. And she really looked at concepts by quite a few of, we have many other researchers and scientists that came into play here and helped her understand even more. And then from there, she continued to develop the program and add even more techniques. So here we did for the diagnostic and therapeutic procedures, she used concepts developed by Laurie and Anakin and Amasov. And for neurological reflex function, she looked at Pavlov and Sechenov and Simonov. And repatterning, which goes with the reflex work we'll be discussing, is based on stimulation of defense functions in the lower brain areas. And this is something that Sechenov discovered. And actually, Tomsky also was with him on that. And Lundy said that stimulating synaptic growth and myelination occurs. And one of the quotes that we all really like in MNRI was by Sechenov, and he said that all acts of conscious and unconscious life are reflexes in their origin. So I just want to pause and read that one more time, a little more slowly, so that you can think about that, because MNRI is very much based on reflex techniques, reflex work. All acts of both conscious and unconscious life are reflexes in their origin. So where should we go for recovery? Where should we go for therapeutic interventions? We should go all the way back to reflexes. That's where we will see the most success. I just wanted to also point out here, Lev Vygotsky, who said the first infant movements, the developmental reflexes, do not disappear. They continue to work in union with higher nervous formations, entering into their structure as the subordinated instances and transferring part of their functions to the higher centers in the brain. So this was Lev Vygotsky, who said this way back in 1930. That was over 90 years ago, right? 90 years ago? And then I just wanted to mention Dr. Nikolai Bernstein, because we will discuss movement that goes with reflexes, and he is known as the father of biomechanics and physiology of movement. So he was very important for the movement pieces that go with reflex integration. And honestly, all of these men, there were so many more. I just wanted to point out just a few of the more important ones so that you could understand the theory and the science behind what we're doing here. So let's talk about a reflex. A reflex is a genetic and epigenetic inherent automatic response of the central nervous system. The response has to be to not just any stimulation, but that stimulation must be adequate, it must be enough, and it must be very specific. The stimulus can be tactile, which is touch, visual, auditory, vestibular, proprioceptive, or even olfactory, which is the sense of smell. So we start with the stimulation, which was step number 1 down in the lower corner of this triangle here. We send this sensory stimulation, say touching the middle of your palm, right? You have the sensory stimulation of somebody pushing on the middle of your palm. This stimulation is going to send a signal to the spinal cord and up the spinal cord to the brain stem, the thalamus, and it gets all the way to the cortex a little bit later. But the main part is once it gets to that brainstem, this is where all the fun stuff will start. So we have a sensory input and then a piece of information that makes its way up to the brain so the brain can process this information and decide what to do with it. After the brain processes the information, it says, I know what I'm supposed to do when someone touches the middle of my palm. I'm supposed to open my hand. So the brain sends a signal to the muscles in the hand, telling the hand to open. Now, again, this response must be adequate and specific. The response can be dynamic, or the response can be more static, postural. The response can be with the glands, the pupils, the tympanic membrane in the ear. It doesn't necessarily have to go to, say, the arms and the legs and the core for big movements. It can go for just positioning and being still into a specific posture, or it can be movement, or it can go to any of the other areas. All right, so that is the definition of the reflex. We have three parts: the sensory input, the processing in the brain, and the motor response. So this is what Dr. Masgutova says about working with reflexes, that when you work with these reflexes, you are touching an underlying net. It's a net that serves like the infrastructure of a leaf or a building, or like a couple slides ago, the foundation of the house. A nice solid base so that you can build from there and build something that's stable, that's not going to fall. What are the goals of these reflexes? You are born with these reflexes. You have them in utero. You're practicing the response to these reflexes in utero. You don't really get the sensory input yet, so you don't have that full circuit, but you're practicing all the motor responses. Right now, you're mostly feeling pressure from the amniotic fluid. And then during the birthing process, once the water breaks, now you've kind of been introduced to some gravity that you weren't really aware of before. And this is where the reflexes really get their first opportunity to become functional and help you through the birthing process. Then let me just talk about that for a moment. So they're going to help you through the birthing process. They're going to give you your very first breath of life. The very first breath of life is the Moro reflex pattern. And when you take that first breath in, it closes off the bypass that was in the heart. So you have a hole in your heart so that circulation, so that you didn't send anything into the lungs, bypassing the lungs, and now that closes so you can start getting get all that oxygen to the lungs so that we can fill up those red blood cells and get all the oxygen to the tissues, right? So from there, after the birthing process, the reflexes are more used the first couple months of life. They're very much used for, the survival things that you need, such as eating, breathing, eliminating, right? And then trying to understand gravity. So you're living in an entirely new environment, and you need to be able to get used to that environment. So the first few months of life, what's most important to the reflexes is protection and survival. It wants you to understand how to live without the boundaries that you had in utero, and now that you have to physically eat and eliminate and breathe all of those things yourself. People are touching you, sounds and lights are brighter, and all of the things that comes with moving into the world. So the first few months, protection and survival. But then once you have gotten used to Earth and used to living outside the womb, and you're feeling more comfortable and you're understanding gravity, then they go into developmental phase. All right. And everything you learn, the first year of life, every single thing you learn is because of these reflexes. All right. It can be learning how to feed yourself with your hands. It can be learning how to talk. It can be learning how to roll over. It can be learning how to make eye contact and smile at your mom, right? Everything you learn that first year of life is because these reflexes laid the foundation for it, a nice big solid base. And from there, you built your house and you started being able to do all of these skills. Once you've learned all of these skills, then you can go on to learning higher level skills like riding a bike and driving a car, things of that, math, right? And grammar and all of those fun things. So once development is, you have that foundation for development, then the reflexes go into their lifelong phase. And in a lifelong phase, they're going to stay with you, but they're going to kind of be on the back burner. They're not going to be in the forefront. So you really don't even know that they're hiding back there and helping you to regulate your stress and helping you to recover from a trauma. All right, these are emotional supports. It could even be, it could be a physical support as well. If you're walking through the woods and you encounter a bear, right? You have to decide, am I going to go in and fight this bear, or do I need to, run the other direction? So this is what the reflexes are for. Now let's take this information and think about our clients who have had this HIE accident. So they have gone all the way back into protection and survival. So those reflexes right now are all about protecting them and helping them to survive this tragedy. So what do we need to do? We want to walk again. We want to eat again. We want to talk again. So we want to use those reflexes to our advantage in order to get past protection and survival, help to understand that you are in a safe environment again, you are here, you are safe, and then move them back into those developmental phases so that you can regain all of the skills that you lost. I just want I want you to understand here what these reflexes are doing. So I've given you two different perspectives here. So here's the first perspective on what these reflexes are doing for us developmentally. So I just took one skill that you would learn in life, and that's sitting, right? And you can see all the babies in this picture are sitting different ways, right? So what reflexes did we use in order to learn how to sit? And I'm sure there are more pieces and parts to this, but here are the highlights. Spinal Perez reflex, spinal galant reflex, trunk extension, a reflex called STNR, which stands for symmetrical tonic neck reflex, ATNR, which stands for asymmetrical tonic neck reflex, our hand supporting, our body and head writing, and our gravity line activation. So that's just a small peek at all of these reflexes that have to be put together and functioning, right, with the proper circuit, with adequate sensory input and adequate motor response, right? Those are the things that need to be in place just to learn how to sit. So here is the second perspective I wanted to share with you, is I just wanted to give you one reflex and show you multiple developmental skills that will be impaired if this reflex is not matured, or what we call integrated. So here we have the spinal Perez reflex. And it is responsible for helping us push up in tummy time, be able to push up on those hands and hold up that head and look around the room. You already knew that it was important for sitting. We just showed that one. It's also important for hands and knees and crawling. It's important for being able to stand up and maintain your balance, both statically and dynamically with walking. And then you really have to have control of that sitting so that you can let go with your hands and do all of your fine motor skills, playing with two-handed objects, eating, and even breath support. All right, so we look at 30 reflexes. And this is just a peek into one reflex and what it's doing for us developmentally. So here are a few pictures of some friends, and I wanted to show you what that prone propping looks like when you do not have spinal parese and what it looks like when you do have spinal parese. So in the upper left picture here, you can see that my friend on the table here was so stiff that her legs were on the table, but we could not get her body on the table at all. Her stomach was not touching the floor here, and she was very nervous in this position. And then the picture just below it, you can see that this friend's belly is on the floor a little bit better, but you can see that the legs are crossed in the back. And do you see how much his arms are really tucked into his body here? So his weight is very much shifted forwards. So there's no way that he could reach an arm out in order to play with a toy. Those arms are tucked all the way up underneath his body here. He's in a very stressed position. So on the right-hand column here, you see what prone propping should look like when you do have spinal parese. And you can see the baby in the top picture here. I put a red curvature here so that you can see that she does have this curvature in her body, which is allowing that belly to rest and allowing her to have her weight shifted backwards so that she can have those arms more in front and she can use those arms to reach out and play. So the tummy's relaxed, the arms are in the front, and she can shift her weight to the right and left so that she can look at someone who's getting her attention over there. And then my friend that was in the yellow shirt on the bottom, this is another picture of him once we did work with that spinal parese reflex. And you can see that he now has some curvature there in his lower back. His arms are a little bit more forward than they were, the left one more so than the right one there, but the legs are no longer crisscrossed. So he has, both legs are getting weight on the table there, and he's just in a more relaxed position overall. And even his head position looks a whole lot better there for vision and looking around. So I just wanted to explain to you that during that process of trying to mature or integrate those reflexes, we do go through 7 phases before we are completely integrated. And those first 3 phases take place in that brainstem, and that's where we are carving out that the pyramid, the triangle that I showed you earlier about sensory input, processing, motor response. We have to build that pathway. And once that pathway is built, we go through a transition period, and then we can start venturing away from the reflex patterns a little bit. So you're not stuck with the motor response every time you get that sensory input. You can now perform like variations of that reflex pattern. And that gives you a little bit of control. This is taking place in the cortex, where that's where you're motivated to do something. It's not a sensory cue that starts that reflex pattern off anymore. It's your own motivation of wanting to do something or wanting to get somewhere. And that gives you a little bit of freedom to perform outside the constraints of the hardcore circuit of the reflex. And so in the beginning, again, you're stuck in that brainstem. This is your unconditioned reflex, those first 3 phases. It's that basic pattern. Everything is purely automatic here. And it's the main job here is more about survival and protection. And then you start, these are your phases 1 through 3. You're starting to carve this pathway little by little as you practice and practice and practice the reflexes over and over. You are creating this pathway until in that last picture in the bottom right, you see that there's definitely a dedicated pathway there. Now it's still bumpy. It's still a dirt road, so it's not going to be high speed. It's not going to be really efficient yet, but the pathway is there. Then we go through that transition phase, which takes place in the middle of the brain in the diencephalon, which is the pathway you take to get up to that cortex. And now those roads are paved. All right, so we have a little bit more efficiency, a little bit better speed. And, but it's still not a big, huge road here. And then once you get to the cortex, now you are fully myelinated, which means you will have full speed, and you can see how those roads branch off going different directions. And that's all the variations that you can have of that reflex pattern now, because you have control. And these are your phases 5 through 7 that take place in the cortex. And here you are with what's called a conditioned reflex. Now that you're in the cortex condition, again, you have more variety. It's more about conscious control, and it's more about your own self-motivation and intent. So our goals, I told you about what are the goals of the reflexes themselves, right? Protection and survival, development, stress regulation, trauma recovery. What are the goals for MNRI when it comes to these reflexes? Our goal is to integrate or mature these reflexes, to lay that foundation down so that house will have stability. And the reason for that is that we need to strengthen our nervous system. We need to strengthen our immune system. We want to build stress resilience. We want to build neuroplasticity and neurodevelopment. I did want to mention here that the MNRI program encourages the facilitation of reflex patterns. That means when we see a reflex is still there and it has not yet matured, we want to encourage that reflex pattern, right? Because that's how the body is going to learn. So we are going to repeatedly move the body through the entire circuit in order to pattern or repattern for development. All right, we have those reflexes for a reason, and if they're not mature yet, we're going to help them along. We're going to be the ones to help them achieve their full potential. All right, inhibition is when those reflexes are kind of discouraged. Instead of encouraged in order to finish their development, they're kind of discouraged, and that can lead to them being erased, and then you've lost your foundation. All right, and delays in these primary movements, these reflexes, these are just some of the symptoms that you can see from them: laziness, your late bloomers, your worriers, the ones who are afraid of everything. You have impulsivity, hyperactivity, aggressive behavior, dyslexia, speech and cognition delays, motor delays, your hyper and your hypotonia, issues with your vestibular and your auditory and your visual systems, poor social, emotional development, and even more. And causes for reflexes not being integrated, just in addition to your HIE injuries, you could have physical or psychological trauma. It could be something hereditary, genetic, complicated birth with issues there, disease, toxicities, any kind of sensory motor deprivation. And then this here, these are just some of the different diagnoses, the other diagnoses in addition to HIE that we work with in MNRI. Autism, Asperger's, ADHD, ADD, your fears and phobias, aggression, fetal alcohol syndrome, seizures, Down syndrome, cerebral palsy, dyslexia, learning disorders, and speech and language disorders. All right, so that teaches you a little bit about what is MNRI. And the program will address not just the reflexes, but remember, a reflex starts with a sensory cue. So that means we also need to address all the different systems in the body. So we need to regulate all the oral facial reflexes. We need to regulate the vestibular system and the auditory system and the tactile system, the visual system and the proprioceptive systems, because these are the systems that are starting our circuit for us. The MNRI program addresses primary motor system and its influence on developmental and learning processes. It's directed toward the restoration of healthy neurosensory motor development and the integration of reflex patterns, motor control systems, and skills for optimal motor and cognitive functioning. And it emphasizes the importance of the primary movements for development. All right, so now you understand what is HIE and how it occurs in the body. And you understand what is MNRI and what are our goals and what are we doing with MNRI. So I wanted to bring this lecture together by explaining to you how MNRI is creating this spark of hope for our HIE survivors. What I am going to show you is some pictures from some of our intensive conferences that we offer. Now, we also offer, we have core specialists all over the world, and you are welcome to go to our website to find someone near you. But in addition to finding a core specialist near you, we do these wonderful family conferences where we offer intensive therapy for anywhere from 5 to 8 days. And the clients have 50-minute sessions, but they will have 50 minutes at anywhere from 4 to 6 different stations every day. So that's 4 to 6 hours of therapy a day, which they all tolerate amazingly well. They love it. So our stations are neurotactile, neurostructural archetypes, our oral, facial, and auditory visual, our repatterning, and then we also have a special protocol. So these stations are specific for our HIE specialized conference that we hold. Neurotactile is going to be the station that is working on regulating that sensory input that starts off the reflex circuit. Neurostructural and archetypes is going to be helping to regulate that motor response, bringing us some body symmetry, regulating muscle tone so that we can give the proper body response to that sensory input. And then the repatterning, that's where we are taking the body through that entire reflex circuit and giving the sensory input and providing the motor response so that we can carve that pathway and make that the beaten down grass into a nice dirt road, into a paved road, and into that fully myelinated highway that we saw. And then we also have, because you do have all your auditory and your visual and your facial reflexes, we have a station to address that. And then for this, for these special clients that we have at this particular conference, we have a special protocol that Dr. Masgutova created just for their needs that really addresses the emotional trauma that they've been through and the stress that they've been through and the breathing issues that they now have, trying to get the respiratory system working correctly and several other things. So the goals for this conference is to lessen the decorticate and decerebrate posturing, which I will show you next, to activate the breathing reflex functions, to create positive survival skills, to establish functions and links between the body planes, to facilitate the process of neuroplasticity so that we can try to reconnect the brain for development, and then lay that foundation that's needed for the developmental skills. So let's just talk one moment about decorticate and decerebrate posturing. Decorticate posturing is a pathological posture where an individual is very stiff. Usually the arms are bent and the fists are clenched, but the legs are usually pretty straight. The arms are bent in towards the body, and the wrists and the fingers held are bent and usually held very much up against the chest. And this type of posturing is a sign of severe damage in the brain. And the decorticate posturing indicates that the damage in the brain is in the corticospinal tract, which is the pathway that goes between the brain and the spinal cord. So you can see a few pictures here of some of our friends that have attended conferences that are in this decorticate posturing. So this is one of the biggest obstacles that we have to overcome in this population, decorticate and decerebrate posturing. So with decerebrate, it's again a pathological posture, but usually instead of those arms being bent in towards the body, the arms are more straight, but the head and the neck are arched backwards. Again, the muscles are tightened and held very rigidly, and this one means that the injury is even lower. It's at a brainstem level. So you can see the little girl in the picture here who was just arched all the way backwards. She could not get out of this position where her head is resting on her back. And then you can see our friend whose arms are bent, but the difference here is that the arms are bent and he's reaching backwards. So he still has that arch in his back and in his head where everything is going behind his body. Whereas with the decorticate, those arms would be more forward and across the chest. That's when the head usually wants to come forwards and the shoulders are more rounded forwards as well. So we did some brain mapping, and I want to show you how MNRI has created this spark of hope, and I wanted to show it to you through two different pathways. And one pathway is just showing you some results from our scientific research that we've done, because everyone loves objective data. But then I'm also going to show some pictures because everybody wants to see happy pictures and the visual proof on how we are providing this spark. So just a few slides here. We have some brain mapping results. The brain mapping was done on the first day of our intensive conferences and the last day of our intensive conference. And out of 53 clients, 42 of them showed positive changes. Brain mapping is looking at the waves, the brain waves, and they put electrodes all over the brain. It's in EEG, but this is more of a functional EEG. And so it's looking at all the different brain waves. So your delta and your theta and alpha, beta, I think high beta also was looked at. 79% showed positive changes from one QEEG to the next. And here are just two cases that you can look at. All right, so this is what the results look like. And here, I'm not going to pretend that I know how to fully read this, but I can tell you that red is not good, and that what you really want is more of the greens and the blues. So you can see the difference between, this is delta, theta, alpha, beta, and high beta brain waves from before and after, and you can see how there's less and less of the red and more of the green and the yellow and the blue. The three rows on the bottom is looking at symmetry in the brain. And then here's just another one where you can see like almost all of the red is gone in the after QEEG here. So the conclusion of the QEEG is that the rehabilitation using MNRI in individuals with cerebral palsy or traumatic brain injury, a lot of our HIE children are diagnosed with cerebral palsy later because of that horrific decorticate posturing. Even if it's not as horrific as you saw in these pictures, they will be diagnosed with cerebral palsy, which is a diagnosis based on muscle tone and the inability to move. So other types of neurological dysfunctions causes a reorganization, at least a partial normalization of the spontaneous brain electrical activity. And it was most frequently observed in the delta and the theta brain waves, which are more about sleeping or being kind of in that stupor before you go to sleep at night, where you're kind of half asleep and half awake. But also in the beta and the high beta, which is being able to focus. This normalization of the QEEG activity is likely correlated with the therapeutic effect of the MNRI program. All right, we also looked at neurotransmitter analysis, and neurotransmitters are it's chemicals in the body that send messages to the muscles and tell the body what it needs to do, the organs. And so these are just some of the things that we looked at here, and then I just have a slide that's going to explain that a little bit better. All right, so we had a positive change in PEA, dopamine, serotonin, taurine, and norepinephrine. And what this means is that we are regulating the stress hormones. We are reducing overall excitability of the system, and we are reducing the inflammatory response. All right, so let's look at some pictures, and it's a little bit easier to understand. And I did show you the little girl on the top left, where she could not get her belly on the table there. She was just in full body hyperextension and could not relax. Her weight bearing, as you can see in the lower left picture, is really just on the ends. It's on her hands and maybe a little bit up from her wrist, but you can see her elbows and a majority of her forearm are off the table. And then after, on day 5 of the conference, she was able to fully weight bear on her forearms. But in addition to that, I was able to bring her up onto her knees, which we could not bend her knees at all in the beginning of this intensive conference. So we had bending of the knees, and she was able to put weight through the arms. And you can even see a little bit of elbow flexion in the picture in the bottom there. And frequently they will hyperextend those elbows, but she has a little bit of what we call shock absorption there in those elbows, that she's weight bearing through the elbow, but she's using her muscles and she's not relying on her joints to keep her in that position. All right. She has a little bit of influence here on a reflex called ATNR, because her head is a little bit turned to the left side, and you can see that that left arm is a little straighter and that right arm is a little bent, and that's that ATNR reflex kicking in right there. She looks a whole lot better though, doesn't she? All right, and so here's another friend who in the beginning of the session was trying to sit, and you can see her sitting posture is very asymmetrical. The legs are crossed over each other. Her arms were not in a great position either in order to play with the ball. And then on day 5, she has beautiful sitting position here. Both hips are rotated out. She has her legs are on the surface to give her a nice base of stability there. And her knees are bent, and she has better separation of her arms here so that we can get the ball in between in order for her to catch and throw with some assistance. And here we have another friend on the left on the first day of conference, and I was trying to roll her over, and you can just see the decerebrate posturing here, how stiff she is. There's no rotation through the core. Everything is just hyper. I had to kind of get my arm in between her legs there. She has no control, and she's, very nervous in this position also because she doesn't, she can't really feel where her body is on this table. There's a very minimal amount of her body weight bearing on this table, so it's a very scary position for her. And afterwards, I took these pictures from a video, so I wish you could actually have seen the arm come across. You have to take my word for it here. But we have some beautiful knee flexion to start the roll with. And I brought the knee across. This is actually called spinning when you start with the knee first. But when I brought the leg across to start this roll for her, first of all, you can see that the hip is forward, but that right arm is still back a little bit. So she does have rotation in the body here, but in that last picture on the bottom where the arm is in the front, she brought that arm across herself. That was all her. So she was reaching and finishing, completing this transition on her own. So here's another friend who in the beginning we were trying to get him on his knees, and he just kept thrusting his body forward because he could not maintain the knee flexion. His knees wanted to go back out into extension, and as the knees went into extension, the body was thrusting forward. And he had no activation of trying to lift his head up off of the table here. And afterwards, 5 days later, you see him on hands and knees. His head is upright. He was able to shift his body front to back, and it's a whole different child, right? A spark of hope for him. All right, and here's another friend with an HIE injury, and on day 1, I stood him up here, and you can just see how he is pushing his body backwards. He cannot get those feet nice and flat. He's compensating in his upper body and his neck and really kind of pushing his weight. He cannot get his weight up over his feet in order to be able to stand. Everything is pushing backwards, pushing backwards. And on day 5, his feet were relaxed here, and we were able to get that weight shifted over his feet. And he had much better midline. Look at the midline positioning. He has both feet flat on the floor. They're separated just enough. The toes are even, and instead of one being in and one being out, and one being forward and one being back. And so here is the same little boy here. I was trying to teach him how to bend his body and curl his body all the way up, and also how to extend his body, not in hyperextension where he's pushing backwards, but in a nice neutral posture that you need in order to maintain your balance. And in the beginning, I could not lift his rib cage here at all. You can see how flat his back is in that upper left picture there. There was just no flexion through that core, and I could not move his pelvis into what's called that posterior tilt in order to get that nice rounded curvature that I was looking for. And afterwards, you can see the difference where you can see that emerging curvature in his spine. And the posterior tilt of his hips being tucked up underneath. And then in the very last picture, you can see his stance here and how symmetrical it is. But do you see how his weight is perfectly over his feet here? And he's not forward and he's not back, but he has his weight just right there in the perfect position with an anterior pelvic tilt. And I have to say that we had this little boy with us this week, and he is walking with assistance and talking and incredibly smart, very, very smart young man. He's really a joy to work with, and MNRI has definitely been a spark of hope for him. And I just wanted to share this one last picture. So this was not taken from one of our conferences, but this is a client that I see privately. And he also had an HIE injury. Now, I've worked with him for quite a while, but I just wanted you to see the difference here in his scoliosis just in an hour. So his body understands this work. I had not seen him in a few weeks, and he came to me in the position that he is in on the left side right there. And it just took me an hour to get him into the position you see that's on the right. His body knew the work, it just needed a few reminders, and he straightened right out. So can you just think about the organs in his abdominal cavity and what he was really crushing over there, and how his lungs, like how do your lungs inflate with air, when they're being crushed like that? His stomach, his spleen, his liver, his gallbladder, everything is just being squeezed together and pushed over to the other side. And, that just kept him in a stressful state all the time because he couldn't breathe and he couldn't digest his food and he was uncomfortable. And getting him back into symmetry there, where all the organs can be properly aligned and all of the body functions can be much more efficient. The breathing calms down, the redness in the face goes away, the seizures diminish, everything. Life is a whole lot better in symmetry. So that's it for today's lecture. And again, I wanted to thank you for coming. This is our website right here, masgutovamethod.com. If you're looking for a core specialist to come to you, that very first drop down in the About category, you can look up specialists in your area. And then we also have a section where you can learn more. We have scientific articles in this section. If you really liked the objective data in this presentation, we also have some parent testimonies if you preferred the pictures and want to hear about all the success stories. And then we offer, again, the conferences, which are under our calendar, which are in green, and then in blue, you will find classes that you can take so that you can learn MNRI techniques yourself. Thank you so much for coming. I enjoyed being here.